Request now Dr. Arun SETHI, who's going to talk about taking ophthalmic care to our community. Arun.
Thank you very much, Professor Tityal. It's a great honor to have you as Vice Chairman and also to present this topic. Well, as you all know, we are a little different. We are a group of private practitioners, a family of private practitioners who started doing community work. We saw our first patient when we came back from Arun in 1990 under a tree. We had no infrastructure. And we've grown from there to cover now 1.6 million poor patients. And we have our own institute in Gurgaon and outreach services in Delhi. So I'll start the thing by saying how to take ophthalmic care to the community. The first thing is you have to have a clear agenda. That is, you should know what is community ophthalmology, what is the importance to integrate eye care, what are the 6 pillars of health system that you're working on, the strategic 5 modules, and the case examples and the challenges that you face. And of course, at the end, the future directions you want to take. So what is community ophthalmology? Community ophthalmology actually means when you merge public health, community medicine and ophthalmology. That's in simple terms how you do community ophthalmology by taking it to the masses. The focus is prevention, early detection, and blindness prevention at the community level. Now, if you can solve most of the issues at community level, then the hospitals get decongested and you can do more systematic work there. Now, why community care? As you can see, that India is a land of curable blindness, and what we show you here is that treatable blindness is the largest portion, which is about 68.1%, and the preventable blindness, which you can see in PHCs and all, is the number 2. And you can also see in the visual impactment slide that the treatment, we can actually do a good job at curing 90.4% of the people by just treating them at primary level. Now, why community eye care? Now, 2.2 billion people are visually impaired worldwide. 55% of these needing care are women and girls, primarily from low and middle income countries like India. And many of the eye conditions are preventable or treatable with proper prevention measures or education. Now, what are the 6 pillars of the healthcare system that I've explained? One is system building blocks. So you actually can see that we can cover a lot more by giving service delivery and health workforce, health information system. They all contribute toward making a quality, safety and access coverage. And then you have the overall goals and the outcomes that come with it. Now, the service delivery. What is important in healthcare is that it should be accessible and equitable eye care programs. So people, Dr. Rohit Khanna from LVP will be talking about that. The health workforce, to have trained eye care professionals, personnel and community volunteers. The community volunteer plays a very important role. It cuts down your cost. It has people in the area who know the population, who can motivate them. So it plays a very big role. Then health information system. Now data has become a big thing. So you'll notice that most of the companies are crunching data and actually surviving on it. One of them is Reliance. And then you have the essential medicines and supplies which you can reach out, because if they are available at the grassroots level, you'll find spectacle dispensation and all that, taking intraocular pressures. It saves a lot of hassle on the part of the patient to come to the hospital. Now, leadership and governance is of prime importance in the community because of the engagement in planning and oversight and in the delivery systems. Now, how do we integrate eye care into primary health care? Eye care has to be a part of the universal health coverage. Unfortunately, it hasn't received that kind of importance, but it deserves. And Professor Praveen Vashisht is here with us, who's been working on it. Then we have co-location of eye care services with primary care. So wherever you have already standing primary health centers of the government or even community halls and all, you can use these to integrate them into centers where a team can go, say, once a week, once a month, depending on the need, and provide the basic services. And those who require referrals are then referred. Then there's an improved referral pathways and monitoring systems. A lot of our patients who we screen in the camps and all get lost. And there will be bigger experts who will tell you that if we go to an eye camp in a village and we screen, say, 50 patients of cataracts, usually not more than 30% land up for surgery. Till you build up a certain reputation, or depends on the enthusiasm of the local organizing committee. So a lot of hard work gets wasted, whereas if 100 are recommended cataract surgeries, 99 should be having them. But that is not the case. Of course, people have a choice, they're scared, they don't want to take a decision, or they don't want it quickly. But the fact remains that we need to have a better output. Then what are the models to do? One is community empowerment. It's very important that eye health education and awareness campaigns are held. and people at the community level are empowered to be able to participate. So we find that wherever we go to centers where the local organizers have done 10, 15, 20 camps enthusiastically, the outcome is much better than where we go on our own, advertise and then organize. Second is hospital-based outreach. So one example is the Operation Eyesight Universal or our team. Now ours is also a base hospital approach, which we learned when we were at fellowship in Arun, where you go into the periphery, screen the patients, provide basic services only, but bring them back or refer them back to your hospital for further treatment and surgeries. So in the good old days when the camps were done, surgical camps used to be held, I remember with CMC Ludhiana, now that system is over and most of the patients are brought back to a proper OT and operated upon. Then there's an integrated service delivery. A lot of times in eye camps you have patients who come there and say that, we have hypertension, we have diabetes, and we say we have no treatment, we are here only for eyes, and they feel a little slighted. So if you can add these also, then it makes it easier, and if you can incorporate eye care in the indications into the national health system, it becomes easier. Technology use, of course, tele-ophthalmology now is a big thing, and you can see we have sessions of that in this conference also, and there's a separate society on how to do that. So what are the success stories? Now you can see that patients have been examined through hospitals. These are the various figures, and we are doing better every year. I won't go into the data because that's Mr. Praveen Vish's area, but as you can see, every year the graph is rising. Now we're reaching a stage where we might plateau out after some time because of the volumes that we are doing, but then that's also a good sign, but still there are underserved areas in the country. Now, challenges in community eye care that we feel, one is limited resources, financial, material and human resources. The first thing is that the level of the non-profits like we run, a small organization, raising consistent funds is very, very difficult. You have a donor, he comes in for say 2 camps, 5 camps or 6 months, and then he says, now I want to do something else or I finished my budget. Whereas if you're in a government service like All India Institute, you have a fixed budget over the year and you know how much you have to spend. And Dr. Tityal, when he was the chairman, was quite liberal in spending that money for community care. Then the other thing is overburdened primary healthcare workers. Recently we did a program to train the ASHA workers in our district in Gurgaon and Patodi. It's very interesting. The feedback that the commissioner office got was, A, if we help you with finding cataract patients, what is the incentive that you will give the ASHA workers? Nothing is done for free. So how much will you pay them? Because they go there, they identify the patient, they accompany the patient, and there was no budget allocation for this. So we decided as our own as an NGO to give a reasonable amount so that they would be motivated. So that is point one. It's very important to know that nothing happens without monetary gain. Second was that they said that they are overburdened because there are other programs. So the government is loading program after program on them, they claim, and they're not able to serve. Third was inadequate referral system and poor supply chain management. Now if we see somebody in one camp and he doesn't come up, when we ring them up, either they've changed the SIM card or the number is not correct, or even after hearing it, they say we will decide when to come. So we lose out on a lot of patients that way. And the other thing is that our staff needs continuous training, empathy and supportive supervision. Now, how do we overcome these barriers? So it's very important to strengthen partnership between governments, NGOs and community. We have to work at one level. It can't be that the government has one plan, the hospital has another plan, and the community wants a third thing to happen. Most of the time in camps, there used to be an emphasis on free medicines, glasses. Ab muft kya de rahe hain? We have moved away from that and we are saying we are giving a service delivery for those who need it. So it's very important to tell them it's not a freebie, but it's actually a community service. Then there's continuous capacity building and training programs. So we have to keep increasing the capacity as the workload increases, which means investments in infrastructure, running costs, then enhancing our health information systems. Then comes finally sustainable financial strategy. Now this is the toughest for NGOs because how do you get a sustainable financial system when you're not sure of what brings tomorrow? So you actually face challenges at every day. And the ones who are lucky enough to grow to a certain size, they're the ones who attract most of the bulk of the donations. So what are the future directions that we recommend? One is emphasize people-centered care and integration of rehabilitation services. So wherever there's a rehabilitation service, if they don't have eye care services, it could be considered to add on to it. Leverage technology for remote screening and referral. Now we have a lot of equipment available which is handheld, like a Perkins tonometer and other things. You can take intraocular pressure, you can do vision with the screen, you can grind and do spectacles right at the spot, as you can see a lot of hospitals are doing. You can scale up in terms of hospital, this healthcare and so on. So you scale successful models and share the best practices that are being done globally and all over the world, and you increase the research and pilot projects to refine and integrate approaches. So in conclusion, community engagement is key to achieving universal eye health. Holistic integration strengthens both eye care and overall health systems, and the call is for collaborative efforts among the stakeholders. If all those providing community eye care could actually pool the resources to some extent, a lot of knowledge, information and equipment can be shared. So with this small talk, we thank you very much for your patient hearing, and I request now Professor Titya to take.